removal of the SGLT2.
Yeah, Professor Leila, do you have any added?
In general, we follow the same guideline, which means it's allowable to see an eGFR drop of about 25%. But if let's say it's above that 25 or even more than 30%, that means it's advisable to stop the or to withhold the SGLT2 inhibitor. So if it falls within the 25% mark, it is common, and we know that it is a transient event, and it will stabilize 4 weeks after that.
Yeah, because I believe now the recommendation we can use certain type of SGLT2 up to 30 mils per minute, 1 meter squared of eGFR. So there are potential drop in eGFR there. So if you started in those patients with lower eGFR, let's say 35 or 40, how frequent do you monitor their serum RP, just like we adopt the ACE inhibitor or ARB? Professor Leila?
Yes, I would do the same, because with the SGLT2 inhibitors, we know there will be a hemodynamic effect of the SGLT2 inhibitor. There will be a transient drop of the eGFR within the first 3 to 4 weeks. So if you do the renal profile within that particular period, you would expect that the eGFR will drop. But to me, there's unless the drop is more than 25%, then of course it would make you a bit more cautious. But otherwise, I would just check the eGFR probably about 2 months or 6 weeks later, whereby by that time the eGFR would have been stabilized.
All right. Another question, I think quite interesting. We have so many types, almost 4 of them, of SGLT2 in the market now. So what would be your prescribing practice? Maybe start with the endocrinologist here first, followed by cardiologist. Is it really class effect? You don't mind? What about the complications? How do you tailor the complications? Which patient would you select?
Yeah, I guess I'll leave to Prof. Azmi to answer.
Sorry, what was it?
The question is your clinical practice. Who do you choose to start on SGLT2? If you choose certain patients, what would be the choice? Because we have so many of them, and how do you tailor the complication or the risk or side effect of the drugs to the patients? How do you tell them?
Okay, initially, before all these CVOT results were published, we tend to give SGLT2 patients to those who are overweight or obese, because we know very well that diabetics, anybody with diabetes, it is extremely difficult for them to lose weight. Yeah, most of the old diabetic drugs, including insulin, tend to make patients gain weight. So once we have a drug that's able to make patient lose weight, then of course that'll be the logical thing to do. Use for patients who are overweight or obese. And of course, second choice would be those with high risk of getting heart failure, those who have pre-existing heart failure, patients with proteinuria, CKD, and in fact, I'm also using it in patients with nephrotic syndrome, Rosalinda. Yeah, because of the Credence study, there's a subset of patients with nephrotic syndrome who seems to benefit from SGLT2. Yeah, so these are the 3 or 4 main criteria for starting SGLT2. In terms of choice, okay, I know Boehringer or any other pharmacologist may not be too pleased with this. At the moment, if you look at all the studies, the cardiovascular outcome trials, the meta-analysis, there is no strong evidence to say that this is a molecule effect. This is a specific molecule effect. Yeah. So far, there's no evidence to negate the fact that we believe all the effects are class effects. Yeah. So it's up to you to choose your choice of SGLT2 inhibitor.
I believe it depends on availability. Then, if you have that drug, use it. If you don't have, use the others.
Yeah,
so
some hospitals chose to put only one SGLT2 in their formulary. Yeah, so I guess then the choice is obvious then.
All right. Prorella, do you want to add on something on that?
Yes, I do agree in terms of the choices. definitely depends on the availability of which agent is available at which particular center. And of course, some of these agents, even the costing, they are different. So again, it also depends on the affordability of the patients. But in general, all SGLT2s has been, from all the clinical trials, we have seen a lot of beneficial effects in terms of the metabolic, the cardiovascular, as well as the renal protection.
All right, Dr. Hamad, do you have any preference or just?
Yeah, this is a very political question. So as I was practicing before, I do think that a lot of medication are coming from a class effect. Okay, I think yeah, some trial maybe give they have a bigger population and maybe give a good answer. But as we go through the history, ranging from ACE inhibitor, ARB, beta blocker, the MRA, so they tend to give a similar effect, even though the newer medication, especially the MRA, there, you see one of the our audience was asking a finerenone. Okay, the new class in the MRA, which is before this was eplerenone. For the history of the eplerenone in our HUKM here, we cannot pick up the demand and the cost. Okay, so we still stick with the usual MRA, which is the spironolactone, which is cheaper and widely available anywhere. So in terms of the newer medications here, which is SGLT2, I don't see much advantage of one drugs over the other, but of course they carry their unique the unique promotion and in terms of their design of the RCT trial itself. So because every trial has their own unique and which target population they are doing. So, but I do like some of the patient who need the combination. So in the metformin and the DAPA combination sometimes is very beneficial to the patient and increase compliance, and they do like the medication much. But having said that, I also use the EMPA in the acute heart failure patient and also in the ACS patient, and also we also tend to start as well in our own clinic, in the cardiology clinic, even without the permission of the endocrine people. So I think they tend to share a similar result at the end because the main mechanism is the same. And but the main thing is maybe to convince them and how we can help the patient in terms of the maybe the private patient, self-paying patient, how we can optimize regarding the cost and also the effectiveness and also the compliance to the medication. So I think yeah, we have to see what is the beneficial of the patient individually and also what is available, the optimized medication we can give to the patient.
Right. Thank you, Dr. Hamad. I think we are at 4:30 now. Maybe one last question to the panelists. So I personally believe even recent American Society of Nephrology Congress stated that the uptake of ACE and ARB worldwide is very low, around 20 to 35%. Even in Malaysia, I'm not sure, maybe Prof. Nur Azmi can enlighten us. So how do you think the uptake of SGLT2 in the management of type 2 diabetes? Because you are clearly stated just now that this drug should be prescribed in obese. Prof. Leila already mentioned that obese are at risk of diabetes. They have microalbuminuria. They are probably in primary care out there. And they have at severe risk. They are still not with us. So is this supposed to be a subspecialty drugs, or should be in the primary care, in GP, as a family physician? What is your comment about that?
All right. Okay. Uh, Rosalinda, SGLT2 inhibitors, by virtue of its action on glucose, on weight, what is actions on heart failure, proteinuria, so on. It should be made available to everyone. Everyone who knows how to use it safely. They shouldn't be limited to any particular specialties. As long as doctors are trained in and are aware of some of the possible problems, then they should be allowed to. I believe, Rosalinda, the market is getting big now. I mean, new SGLT2 are coming into the market, even from Japan. There's a SGLT2 from Japan, and there's going to be one from Taiwan. So this, with the increasing number of SGLT2, that should provide good, healthy competition, and that will, in the end, bring down the price of drugs and make it readily accessible for everyone.
It's great to hear that. Anything else, and any other speakers would like to add on? Prof. Leila?
I think in terms of the availability, because of the currently available evidence, not only in the metabolic but also in the cardiology and the nephrology perspective, I think this agent should be made widely available. It's just that it is important for us to educate our healthcare providers in terms of, I'm sure many of them would know about the benefits, but in terms of the possible potential side effects, that most of them are actually avoidable. So when we give our patients SGLT2 inhibitors, I think it's important for us to give a bit of counseling because, for example, like the euglycemic DKA, the genital infections, urinary tract infections, and all the other side effects, they are potentially avoidable. So it is important to advise our healthcare provider in terms of all these potential side effects, because the benefit of this agent is a lot, it's tremendous.
Any last message, Dr. Hamad?
Yeah, I think I do agree that the pickup of the ACE inhibitor and ARB especially in the diabetic group and in medical clinic, they are quite quite low, and of course the SGLT2 pickup also takes time. I think in a way that our management in some way the system, sometimes we left the clinic. Sometimes I see that we left the clinic to the busy clinic in the hands of the MO to decide. Sometimes it's quite difficult to go and see all the MO what they are doing. Sometimes they are really enthusiasts that see the medications, see what's the main problems. And I've seen a lot in some of the clinic that the diabetes for many years, and they never was put on the ACE inhibitor or ARB. I do agree with that. So I think in terms of the SGLT2, specifically in heart failure, maybe it takes time, and I think it's almost near the end of the medication that we need to consider, especially the non-diabetic group. So for diabetic, maybe we can start early. For non-diabetic group, in terms of the optimization of the medical therapy, maybe we need to go by history and by the mortality benefit that been shown in the evidence and also guideline. So we go one by one, and of course, if we have a good follow-up, I think the additional medication like SGLT2 in the heart failure in non-diabetic group, of course, can pick up by time.
All right. Thank you so much again to all the three panelists. Excellent talk, very thoughtful sessions, and we have nearly 400 participants today. And I hope that this session will benefit them. So I believe, in summary, the incidence and prevalence of diabetes with comorbidities, heart failure, and CKD will continue to rise. As nephrologist Prof. Leila even pointed out, the major cause of end-stage renal failure is still diabetes. And I really looking forward the drugs that can prevent CKD progressions, halt the progression, don't allow them to go into end-stage renal failure. And I hope the SGLT2 are not just glucose-lowering agents. This drug can be used in other therapies such as heart failure and also diabetic CKD patient with albuminuria. So what do we need? In conclusion, is as pointed by the speakers, multidisciplinary approach. And we do hope, as what Prof. Azmi pointed out, the uptake of SGLT2 will be better than ACE or ARB. It depends on accessibility, availability, unfortunately, I have to say this, affordability. With that, I return back the sessions to the pen from the Beringer in Helm. Thank you so much for having us today for this excellent session. Thank you so much.
Thank you very much to the sponsor.